الله الرحمن الرحيم. الصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Tonight it is a great honor and pleasure for me to introduce one of the most famous scientists in the field of anesthesia in Egypt and in the Middle East, our Professor Major General Professor Dr. Nabil Elaskalany. Professor Nabil Elaskalany is the president of the Egyptian Society of Anesthesiologists, and it is a great pleasure for me to introduce one of the sons of the Asyut government. Asyut government, which is in the upper Egypt, and I am proud that I am one of the sons of this government. So it is a great pleasure, and I am proud to be with my professor today, Major General Professor Nabil Elaskalany. And Professor Nabil Elaskalany is MD Anesthesia, MSc Anesthesia, and MSc in Aviation Medicine. He has the Diploma of Aircraft Investigations and Safety Management, University of Southern California, USA. He is a professor of anesthesia, Military Medical Academy. He is now the president of the Egyptian Society of Anesthesiologists. He was the ex-dean of medical services in Egyptian Air Forces, ex-commander of Air Forces Hospital, and ex-dean of the Aero Medical Aviation Institute in Egypt. He also was ex-head of anesthesia department in Air Forces Hospital. Besides all of this, we consider Professor Nabil Elaskalany is one of the references in the anesthesia in Egypt. And he is personally, we respect his personality, and we are proud so much to be with him today. And he will speak about a very important subjects today about the ethics in the medical and skills in the disclosing the medical errors. And of course, I'm sure all of us, were confronted with a lot of medical errors in the field of anesthesia. So he will disclose the medical errors and adverse events today. So we are waiting for the lecture from our Professor Nabil Elaskalany. Please, sir. Floor is yours. Thank you so much.
First of all, I find no words to convey my thanks to my dear colleague, Professor Assam Manna, together with other colleagues, Professor Saad Al-Mahdi, Dr. Adil Ibrahim, and all colleagues. As a matter of fact, it's a great honor to me to participate in your webinar. The topic of my speech today is the ethics and skills of disclosing medical errors and adverse events. As a matter of fact, this topic is quite important. Our target, or the target which is universally present, is safety of the patient. That's the main target. So adverse events and medical errors is a major health problem which affects the safety of the patient. In the meantime, disclosure of these adverse events is not universal, and in the meantime, it needs special skill from the person to disclose this error. As regards the ethics, there is a general consensus from the ethicists that medical errors which are harmful to the patient should be disclosed to him. Disclosing medical errors enhance the patient's safety, and medical errors shouldn't, for the dignity of the surgeon or the physician, shouldn't be undisclosed. Okay, if we say it this way, Are there barriers to disclosure of medical errors? Sure, there are a lot of barriers to disclosure of medical errors. First of which is fearing of consequences, fearing of litigation, fearing lawsuits. In the meantime, the surgeon or the physician loses his dignity, loses self-confidence, loses trust, because the relationship between the physician and the patient is that of trust. Okay, do disclosure of or do medical errors and adverse events affect the patient only, or in the meantime they affect the surgeon or the physician? As a matter of fact, they affect the surgeon and the physician like the patient, and even more. And we're all subjected to medical errors that occur, and you don't know what's the prognosis. In the meantime, you don't sleep because you don't know what's going to happen. So we'll highlight all these topics. What about compensation programs? Do they diminish the lawsuits and diminish the complaints? What are the actions that are taken in the United Kingdom after medical errors? Should we report to a higher authority the harmful medical errors? In the meantime, what's an apology? Is the apology a sort of admittance of fault? If I apologize to a patient, this means that I admit that I have done a fault. What about medical malpractice claimants? What about litigation? What about the apologists and physicians? Do physicians apologize more or surgeons? What are the barriers to apologies after medical errors? Are there effective guidelines for apologists, evidence-based guidelines for apologists? What are effective apologists, and what is the receptivity of apologists in the medical profession? They increase nowadays. So, efforts to improve the patient safety remain an international focus in healthcare delivery. Adverse events and medical errors are a major health problem. Some consider that medical errors are preventable adverse effects, but as a matter of fact, this is debatable. As all errors are truly, it is debatable that all errors are truly preventable. In the meantime, we should differentiate between honest mistakes and negligent actions. So if it's an honest mistake, there is no problem. But if it's a negligent action, the surgeon should be file suit. Okay. If we have got a tight healthcare program, would this make the medical errors zero? No, never. It can never happen this way. Medical errors will continue to occur in spite of improving the quality of healthcare. How to disclose harmful medical errors and whether to disclose them or not to patients, this is a challenge as a matter of fact. So physicians should integrate their understanding of the following 4 items: the bioethics, the doctor-patient communication, and the team-based care delivery and the quality of care. As a matter of fact, efforts to improve patient safety remain an international course, an international focus in healthcare delivery. Anyhow, there is a general consensus among ethicists that harmful errors should be disclosed to patients. In spite of this, disclosure is uncommon. In spite of the general consensus that we should disclose it, but disclosure is uncommon, and it varies widely from one country to the other according to the culture. Ethical standards articulated by the American College of Physicians and the American Medical Association oblige the disclosure of errors. So in the United States and in Canada, it's a must to disclose the medical error, but in other countries, you've got the choice to disclose it or not. And this depends upon the culture of the people in which you are going to disclose. For instance, in some low-income countries, if a patient is in the intensive care and his case is doomed and he dies, sometimes the relatives of the patients beat the doctors. So would you disclose a medical error to such people? That's a point to be discussed. Anyhow, ethics focus on the necessity for trust between the physician and the patient. The relation between the physician and the patient is one that involves three items. There should be considerable intimacy, considerable vulnerability, and considerable trust. Medical errors, as a matter of fact, injure this relationship. As we said before, there are barriers to disclosure of medical errors. What are these barriers? First of all is the fear of consequences. Secondly, the fear of litigations. Thirdly, the fear of attitudes about disclosure. And finally, the lack of skills and lack of peer and institutional support. For instance, if you're working in a certain hospital or institution or organization, and they don't give you support to disclose the medical error, you're the only loser. You should look for support from your organization, and we should change our mentality as regard organizations or hospitals and things of that sort. What about compensation programs? As a matter of fact, compensation programs decrease the litigation and improve the disclosure of adverse events. What do we mean by compensation programs? These programs encourage honest discussion between the physician and the patient about the event that occurred. Compensation may make disclosure less adversarial. Patients have rights and providers or physicians have responsibilities. So the quality of medical care can be enhanced by medical error disclosure. By compensation, we mean that we give the patient some sort of financial compensation. So this will decrease the litigation. Apart from financial litigation, you can waive the extra fees that he's going to pay in the hospital for the medical error that occurred. This diminishes the litigation and makes some sort of trust between the physician and the patient. What are the actions desired following an adverse event in the United Kingdom? In a survey done, 34% of the patients require an apology and explanation. As a matter of fact, this is the point of argue. A lot of physicians or surgeons, they do not apologize and do not explain to the patients. In the meantime, some patients endorse punitive measures for healthcare professionals following an adverse event. That is, they want the physician or the doctor to be punished. It's some sort of revenge. In the meantime, it is mandatory for healthcare organizations to report serious adverse events to external agency. That's in the UK. Finally, waiving of the additional medical fees, as I said before, as a result of an adverse event, and financial compensation for any injury, pain, or suffering caused the medical error or caused by the medical error. So financial compensation and waiving of extra fees is a must in the UK, and this diminishes the medical complaints and the litigation. When I used to work in the Royal Free Hospital in London, they used at the end of the year to give a book including all the medical errors that occurred anonymously. You don't mention the name of the surgeon or the physician for his dignity. The target of this is to avoid further recurrence. So the target is to avoid recurrence of the same error that may cause harm to the patient. This occurs in the air forces. For instance, in the United States of America, when a plane mishap occurs and anesthesia is like the plane, the most serious periods are the induction and the recovery, and this is like takeoff and landing in the airplane. So whenever a mishap occurs and the pilot is still alive, the pilot is always inquired in front of an accident investigation team, and his words are videotaped. In the meantime, the videotape is to avoid further recurrence. When he sits in front of official authorities, he can change his words, and they can never use the videotaped things against him. So the target is not punishment of the pilot. The target is avoidance of further mishaps. Same thing applies to anesthesia. If we know the adverse events, even anonymously, and that's what occurs in the UK, the number of mishaps will diminish. As regards the apology, is an apology a sort of admission of fault? If I apologize to the patient, this means that I've done a fault. How can we handle apologies effectively is an issue for error disclosure. Patient safety requires no secrecy of error, as I said before, for a doctor's dignity. This could be done anonymously. One way in which physicians can respond to a medical error is to apologize. And there's a great difference between an apology and regret, and this will come to forwardly. What's an apology? The apology should have 3 items. Apologies are statements that acknowledge an error and its consequences. That's the first time, acknowledging an error, taking responsibility, and in the meantime, communicating regret for having caused harm. So, acknowledging an error, taking responsibility, and communicate regret. Does the apology improve the condition? Yeah, the apology may lead to, it decreases the blame, decreases the anger, increases the trust between the surgeon and the patient. It improves the relationships. In the meantime, it decreases the risk of medical malpractice lawsuit as far as an apology occurred. In the meantime, it can help to settle claims by patients. As a matter of fact, patients expect explanations and apologies after medical errors, and this doesn't occur frequently. In practice, physicians tend to provide minimal information to patients after medical errors, infrequently offer complete apologies. And that is one of the main causes of file suiting or medical claimants. If they received an apology or an explanation, they wouldn't have filed suit. An apology is a statement given by one who has injured another that includes, first of all, a recognition of the error that has occurred. Secondly, admits the fault and takes responsibility. Thirdly, communicates a sincere sense of regret for having caused harm. Is there a difference between an apology and a complete apology? Yeah. Complete apologies include promises to refrain from engaging similar conduct in the future. And this is one of the main targets of the patients or the relative of patients, is to avoid the same thing from happening to another patient. Secondly, a complete apology should include compensation for the harm that had occurred. Do apologies have positive effects? That's sure they have positive effects on the following items: expectations and intentions for a future relationship between the parties. Apologies have positive effects on restoring trust between the surgeon and the patient. They reduce the negative emotional reactions such as anger. In the meantime, they induce favorable psychological responses in both parties. And finally, they reduce antagonistic responses. What about apologies and patients? Patients worry about apologies of medical treatment, particularly outcomes that result from medical errors. In a survey, 98% of the patients desired and expected the following: to be informed promptly about a medical error, which doesn't happen, to be given information about what occurred, why and how it occurred, how their health will be affected, what steps will be taken to prevent future harm, and to receive an apology that signals a sense of regret. What about medical malpractice claimants? Vincent and colleagues surveyed medical malpractice claimants about reasons they file suit. Why do the patients file suit? Over 90% of those who responded indicated that they wanted to prevent the same thing from happening to someone else. So as I said before, the first target is prevention of recurrence. Secondly, to receive an explanation for what happened. Thirdly, for the doctors to realize what they had done. As a matter of fact, 40% reported that if they had received an explanation and the apology, they wouldn't have felt the need to file suit. So, giving an explanation to the patients promptly after a medical error and an apology will diminish the file suiting to a great extent. What about litigation? Other studies have found that failure to provide explanations and poor communication are generally associated with litigation. The target is a desire to deter subsequent malpractice by the physician and to seek revenge. So the target from litigation is revenge and subsequent malpractice to be diminished or prevented. What about apologies and physicians? And who gives apologies, the apologies more, the physicians or the surgeon? As a matter of fact, physicians. As I said before, the physicians are affected by the medical errors like the patient and even more. So physicians are profoundly affected by medical errors. The physicians worry about harm caused to the patients. The physicians are anxious about the consequences for the error. For the following conditions: the reputation, they're afraid for the reputation, fearing that patients and colleagues will no longer trust and respect them. Thirdly, experience distress, feeling of guilt, self-guilt. The physician feels he is guilty if the mistake is not due to negligence. Fourthly, loss of confidence or loss of self-confidence. And finally, he is anxious from having a lawsuit. Anyhow, there is a wide variation in physicians' tendencies to offer apologies for medical errors. In one survey, respondents had experienced medical error in their family. Only 1/3 reported that they had received an explanation or apology for what had happened. So a lot of people, they don't receive an explanation and they don't receive an apology, and that's why they file suit. What about error disclosure by surgeons? In a study of error disclosure by surgeons, there was wide variation in disclosure practices. 57% referred to the error as an error or mistake. Others described the event as a complication or problem. So the way of disclosing the error differs from one surgeon to the other. So saying it's a problem, saying it's a complication, and in the regret, it differs widely from an explicit apology to saying, for instance, I'm sorry to have to tell you that so and so occurred. 16% didn't indicate that the outcome was preventable, and 65% took a responsibility for the error. In the meantime, 47% offer some expression of apology or regret to the patient. Expressions ranged from explicit apologies for the error to much less direct statement of regret. I'm sorry to have to tell you this, as I said before. Surgical specialists were less likely to apologize than medical specialists. In another study, 61% of the physicians would express regret for the adverse outcome, and 33% would apologize in a way that acknowledged the error, and 6% would offer no apology. The inclination to offer an apology was smaller when the error was one that would be less apparent to the patient. So if the medical error is unapparent to the patient, they don't offer any apology. What are the barriers to apologies after medical error? First of which is fear of litigation, fear of legal liability. In the meantime, to admit that an error has occurred and to apologize for it is embarrassing and injurious to one's pride. So the surgeon feels that his pride is going to be injured if he admits the error. Lack of certainty and skill about how to go about disclosing error and apologizing for them may prevent many physicians for engaging in such conversations. So as you said in the very start, that disclosing the medical errors needs special skill, and now is even in the curriculum of some medical school how to disclose medical errors. What are effective apologies? Apologies that accept responsibility for having caused harm are more effective than similar expressions that simply express sympathy. So, if the apology is accompanied by an offer for compensation, this can influence its impact. As I said before, financial compensation is a target for the patient and his relatives as far as there is a medical error. In the United States, the National Quality Forum puts forward an evidence-based safe practice guideline regarding the disclosure of serious unanticipated outcomes. And this is very important. So we have got evidence-based guidelines. What are these guidelines? First of all, disclosure should include, or disclosure of medical errors, an explanation of what had happened, the implications for the patient. Shall this affect the future of the patient or not? In the meantime, there should be a commitment to investigate and feedback about such investigation. So if the cause of what's occurring in the patient is not clear and is not due to a medical error, further investigation is required, and feedback for this investigation to the relatives of the patient is a must. The guidelines advises physicians to express regret to the patient, regret and not apology. This is when the adverse outcome, when there is an adverse outcome and not a medical error, and to apologize when there has been an error. So this should be very clear. The guidelines need regret when it's an adverse outcome and apology when there is a medical error. What about the receptivity to apologies in the medical profession? There is an increasing receptivity within the medical profession to apologizing to patients who have been injured by medical errors. Some medical schools are now starting to incorporate training about error disclosure and apologies into the curriculum. And as is apparent, medical errors are the third leading cause of death after heart diseases and cancer. So it's something worth. What about the receptivity to apologies in the medical profession? Incorporating apologies as part of the disclosure of medical errors can benefit both partners, the patients and the caregivers. An apology that accepts responsibility for an error and the harm caused may be most appropriate when it is clear that an error has caused harm. So when an error causes harm, an apology is a must. If the adverse outcome was not the result of an error, an explanation of the cause of the complication coupled with an expression of regret for the outcome and sympathy for the patient condition seems more appropriate. So to make it clear, if the guidelines, the evidence-based guidelines indicate that if the adverse outcome is not due to an error, a sort of regret and sympathy should occur to the patient. But if it was due to a medical error, an apology is required. Sincere apologies. Sincere apologies for a medical error may lead to lessening of suffering for both patients and physicians in coping with the error and its consequences, contribute to improved relationships between physicians and patients, reduce the costs by preventing lawsuits, and it facilitates the settlement of valid claims. So if there are valid claims, you can settle the condition. So sincere apologies is a must, and it improves the condition very much. Take-home message. Both healthcare professionals and patients support the concept disclosing adverse events when they occur. So both partners accept or support the concept of disclosing the adverse events. Despite this agreement, disclosure is still far from universal. In the meantime, adverse events are increasingly recognized as a source of harm to the patients. Problems arise in communicating the situation to the patients and their families, and there's a great variation between countries in disclosing adverse effects. As I said, it depends upon the culture of the patient and his relatives. In some countries, it is obligatory, like in the United States and Canada. In the meantime, organizations' policies as regards disclosure of medical vary widely. Healthcare professionals should be assured with hospital disclosure policies that they will be supported by the institution in disclosing the adverse events. Increased openness and honestly following adverse events can improve provider-patient relationships. In the meantime, patients want assurances that they will not suffer financially due to an error. So as I said, waiving of the financial fees for any medical error that occurred, as it occurs in London, and a sort of financial compensation. Fear of medical malpractice and litigation has been identified as an important barrier to disclosure. Physicians desire training to handle adverse events. Thank you very much for listening.
Prof, thank you so much for this very informative and interesting lecture in the field of the ethics of the anesthesia and how to deal with these adverse effects. And I think to apologize for the family from, as you said, and as you mentioned, Prof, from the side of the anesthetist, we should encourage ourselves to this culture. And I think we have some of the questions written here. One of our colleagues is asking, in some developing countries, the patient's family doesn't accept ability of the physician. I think apology of the physician if an expected complication is inevitable. Some patients with multiple and severe comorbidities. What is the right way, Prof, to avoid litigation?
Well, as I said before, sometimes even if the doctor is honest and the patient dies in the intensive care and his condition is very severe, sometimes the relatives beat the doctor. It happens. I said it depends upon the culture. And when I'm speaking, I'm not speaking about anesthetists only or intensivists only, but even surgeons and physicians. So the proper way is to be very frank with the patient, but according to his culture. Or you choose someone of those who are cultured or educated in the family and tell him the facts. This increases the trust between both parties. And if you offer compensation and you waive the extra medical fees, he will accept this because they can't afford to pay.
Prof, I have some of comments and question, if you please.
You're most welcome.
Regarding, thank you, sir. I think all of us in our field of experience, we met some of the medical errors by ourselves or by our colleagues, and we heard about fatal medical errors like infusion of potassium, for example, or insulin by error. And this may lead, or not may lead, leads to the morbidity and for
mortality.
the patient.
Even it may lead to mortality. You give adrenaline instead of atropine.
Yes, for mortality. And I think the communication between the anesthesiologist and the pharmacy is one of the most important items for declaration of the drugs, for putting, for example, high alarm or just marking of coloring marking for the drugs to avoid of some of these errors. One of also of the most important educational method to learn and to teach from the medical errors is the meeting of mortality morbidity, I think. What do you think, Prof, about this?
I agree with you absolutely. Concerning the mixture of drugs together, as you said, you've given the answer yourself. You've got tapes, colored tapes to avoid this. For instance, muscle relaxants have got a certain tape. Narcotics have got another colored tape. So in this way, we can avoid this. Apart from this, it is to be noted that the anesthesiologist is the one responsible for the drug he gives. So a lot of us let the nurse or any other one prepare the drug for him. You should see at least the empty ampoule, at least, because medico-legally, you're the one in charge and the one responsible. As I said before, the target is not punishing of the anesthetist. The target is to avoid further recurrence. So as you said, if we make conferences concerning the mortality and the morbidity that occur, sometimes in some places they make a weekly conference. And as I said before, if you give anonymous cause of mortality or morbidity and discuss it in this way, you'll improve the condition.
Prof, another comment regarding to our juniors, regarding the residents and our colleagues. Do you agree with me that the overload, sometimes the overload on the on-call or in the list may lead to this error? We should help our juniors and give them the time for teaching, for learning, for giving them some of the hours for teaching them and giving them the chance to take rest or breaks, not to make overload for our juniors, because this may lead to this event and mishaps. And if this happened, Prof, is it the responsibility of the junior in the room or the senior and the juniors?
Well, from the legal point of view, it is the responsibility of the junior. It's not the responsibility of the senior.
The junior?
Yeah.
Okay.
As far as the senior didn't give him the proper way of handling things. As a matter of fact, anesthesia in itself forces some of the junior staff to work day and night because the fees of the anesthetist is not promising. And he's got a family and he needs money. And as a society, we met the Minister of Health and Medical Syndicate, the dean of the medical syndicate, but unfortunately, we didn't manage, it's a complicated problem. We didn't manage to raise the fees of the anesthetists. And as a society, I'll tell you something. For instance, one of the junior anesthetists anesthetized a case of cesarean section. He gave spinal anesthesia in a private hospital in the countryside, and the private hospital is just 2 apartments in a building. And then they asked him, there is another private hospital in the building beside, and there was another cesarean section. So they asked him to give anesthesia. He just left the first case and went to give spinal to the second case. They told him that the first case is suffering, and he went, the first case died, and the second case died, and he came to the society telling us to give him a letter that he hasn't done a mistake. That makes no sense by all means.
Very bad scenario.
Yeah, it's something horrible. But as I said, the conditions of the anesthesia as fees forces some of the junior staff to do so. Another case, for instance, one has given spinal in a clinic, and then it turned to be total spinal, and there was no anesthetic machine in the clinic. The patient didn't die, but suffered from total mental confusion. The relatives of the patient said, we don't accept money. We want the doctor to be in jail. And finally, he gave them money. He gave them all what he's taken during all his life. So that's a point to be put in mind.
Big point.
Another thing I'd like to say, the consent is very important to the anesthetist. He should take the consent, however, he is busy. And I'll say something that happened to me personally. There was a wife who's had 5 children, and she entered because she suffered from pyosalpinx or hydrosalpinx. When she entered, she had 5 children, her husband was present, her mother was present, and the doctor asked them, let's make hysterectomy in the same session. She's done hysterectomy. She was raised in a British school. She got her sheet. She managed to receive her sheet. And she asked me a very frank question. Did they do hysterectomy for me? I told her, yes, it happened. Why? To save you taking anesthesia for 2 times. She said, couldn't this operation be postponed for 1 week or 2 weeks until I recover? I told her, yeah, it could be postponed. She filed sued us all. And she said, neither my mother nor my husband has got the right to sign the consent for me as far as it is not a life-saving measure. So we should be very cautious as regards the consent, the medical consent.
If Prof, something happened related to the surgical maneuver.
Yeah.
And I am the anesthetist, of course, in the room. I'll be included in this mishaps?
I didn't get the question. Please repeat it once more.
If side effects or the surgeon, did mistakes.
Yeah.
Is it my fault as anesthetist? I'll be included should be apologize for the family, or will be included in this issue?
Well, I'll tell you something.
I mean, the fault or the medical error is away from the anesthetist.
I know, it's the surgeon. Yes. It happened once with me personally. The surgeon was doing laparoscopic cholecystectomy, and he was one of the very brilliant surgeons. But in the meantime, he injured the artery, and the patient received 10 packs of blood, fresh frozen plasma, and so on. And the operation, instead, he used to take 20 minutes. It took over 6 to 8 hours, and the patient died. The surgeon told me, I'll go to his relatives and get it to them smoothly. I found the wife of this general doing the operation came to me and told me, the surgeon told us that he finished the operation and he gave us the gallbladder, and that they are wakening him from anesthesia. Imagine what happened. So I asked the wife to get if she's got a man with her, and I got the man into the operating theater. I showed him that still the patient was on the operating theater, dead and not closed. The window was still open. And I kept the jars that contained the blood. I kept all the jars. And this way, this general, he went to pension. So we should be very cautious from surgeons. They will never support you. They will never support you. But in the meantime, if the surgeon and the anesthetist won't be one hand, they might suffer both of them. For instance, in mishaps in airplanes, when a mishap occurs, they differ, the pilot from the assistant, so that they wouldn't prepare the words, and they take the words from each one separately. That's a way to know the truth. So if the surgeon and the anesthetist, they'll both suffer. They'll both suffer. But the anesthetist should be very cautious, because the surgeon will never support him. He's looking for his name, for his dignity, for his attitude, and he'll tell you, I am known, a well-known name, the anesthetist is unknown, so I'll get it in anesthesia. This is never accepted nowadays, because the people now realize that the anesthetist is something different. The anesthetist is in charge of intensive care, in charge of anesthesia, in charge of pain relief, and the people started to ask for the name of the anesthetist before the search.
Yes, yes. I think we should pray all together to avoid and to be away from the medical error, because this is very dangerous for us and for the patient. We have some of the comments, Prof, from our senior Professor Salah Al-Tallawi from Minya University. You know him well, and he is my senior. He is mentioning that he thinks that the culture is completely different in our area, and it is difficult to implement such value guidelines in our society. And also there are some barriers that make this difficult. The most important is the lack of documentation or fabricated documentation. What do you think, Prof, about this comment?
I agree with him absolutely. And I said in the very start, the cultural difference from one area to the other. But I'm speaking about, for instance, those working in Cairo or working in Alexandria. Some of the people are well cultured, and they have got the right to know what happens. It differs from, and I said before even that they beat the doctors because of the bad culture. So he can't disclose errors with such people, But in the meantime, such people will file suit him if a complication occurred. So he should try in whichever way to gain their trust.
Okay. What if pneumothorax during CVB insertion, should I tell the relative, yeah, Prof?
Excuse me?
If pneumothorax happened during CVB insertion, this is one of the question. Should I tell the relative, and how can I tell them?
First of all, that's a normal complication. It happens. It's not a medical error. You don't consider it. It's recorded in books. So it's not a medical error. I should disclose the condition, and the patient, as far as it's diagnosed in the proper time, the patient will recover.
Okay. I think for this, we can stop for taking questions, because there are a lot of questions, because this is very interesting lecture and very rare to listen about the side effects and the error during medical errors, and how to avoid these medical errors and disclose medical error. So thank you so much, Professor Nabil, for your time, and we appreciate this very informative lecture.